Avast me, hearties. Is it time to finally get rid of that old salty dog of the sea, saline? What other solutions can we use for fluid resuscitation in the field? Stay tuned, we've got a show here for you today. So what is the ideal solution to use in fluid resuscitation? Well, that's an excellent question. What is the perfect solution? Well, unfortunately, the best solution really can't be replaced. The best solution is whole blood, and preferably the patient's own blood. Now, for lots of logistical reasons, cost reasons, supply reasons, this might not be practical to have on every single ambulance service across the entire country. So what solution can we have as an engineered solution that is practical and sustainable and really the best option for patients who need to undergo fluid resuscitation as volume expanders? Well, right now, traditionally, we are using saline, but is there a better option? To look at this, we're going to have to take a step back. We're going to have to consider what's practical, what's sustainable, and of all the metrics, what is best for general population use as far as fluid resuscitation. So let's back it up and let's take a look at two blind solutions, right? Pretend that we don't have an established practice where saline is the most common fluid around. So let's take a look at this. In a showdown, solution A, solution B. Let's take a look at trauma, where most people traditionally consider the use of saline and other fluids. Solution A, in this particular case, uses 25 to 33% less fluid, restores base excess, it improves pH, and lowers the rates of extravascular lung water. And it also promotes clotting. Some may argue perhaps sometimes a little bit too much clotting. And what about solution B? Well, it decreases peripheral vascular resistance, it causes acidosis, and has great dilutional coagulopathy. Wait a minute. It has decreased peripheral vascular resistance, acidosis, and coagulopathy. That sounds like the opposite of what we want in trauma. Huh. How peculiar. And all this results in more blood loss. Right, well, let's take a look at a different case. Maybe sepsis might have better application for solution B in this particular case. Now, as we know, fluids in trauma, they are tending to go less in favor of that now for something more like permissive hypotension. So with sepsis, we're actually seeing higher fluid volumes, sometimes as much as 30 cc's per kilo, based on data from the RIVER study. Now, there might be some methodological issues with the way that the RIVER study was performed and was adopted into widespread practice. But as it so happens, sepsis does tend to get lots of fluids. So let's take a look at sepsis from a fluid A and fluid B standpoint. So fluid A, well, it's less damaging to the gycocalyx, which is one of the issues with the way that fluid resuscitation sometimes can damage the endothelial lining of the vascular wall. It restores base excess, improves pH, and has lower rates of extravascular lung water. It also has a lower mortality compared to solution B, and it decreases cellular death from ischemia, so it has some protective properties as well. Now, solution B has earlier onset of oliguria, which means not enough urine. Earlier death causes acidosis. None of this sounds like something that we want to cause. And it reduces tissue oxygen. And it also has a higher need for pressor agents than solution A. Well, this doesn't really sound like progress. And it also reduces the cardiac index. Maybe solution A is looking better and better. And it also increases pro-inflammatory cytokines, specifically the interleukin subtype. Maybe solution B is not that great at sepsis either. Right. How about hyperkalemia? What kind of fluid solution would we use for that? Well, solution A gives us, well, it doesn't increase the potassium. And solution B actually can cause an increase in potassium over solution A. Well, maybe it's not suitable for that particular usage either. Well, maybe we'll find a use application for solution B after all. Let's keep looking at this a little bit further. How about dehydration? Surely solution B might have some application here. Let's see, in the application of dehydration, solution A has faster resolution of acidosis. It does not cause hyperlactatemia, whereas solution B causes hyperchloremia. Okay, let's move on to how about kidney injuries. Maybe there's some better application here. So as far as acute kidney injury, solution A has lower fluid volumes needed than solution B, reduces the need for blood transfusions, and has fewer instances of hyperlactatemia. It also has fewer instances of hyperchloremia, so has lower instances of various different acidotic things that are bad for renal function. Let's see, the best thing we can say about solution B is that it has no difference in 28-day mortality over solution A. That's not really a strong selling point, given all the other metrics. All right, how about this? Let's look at one of the largest studies of 10,000 plus ICU patients. These are critically ill patients. These are patients that have various different conditions that are causing them to have renal issues and perfusion issues, and may need a lot of fluid resuscitation. Let's take a look and see which fluid is better for the critically ill patient in the ICU. See, solution A has reduced hospital mortality, it has reduced acute kidney injury, and, well, solution B is, well, I guess it's better than nothing. So, I guess really there isn't a lot of selling points for solution B. So it might not come as a particular surprise that the winner is solution A. Objectively, if we're looking at the evidence of which solution is better, A or B, there's no arguing that we'd have to go with solution A because it is better on so many different levels. So what is the winner? What is solution A? Well, it may surprise you to learn that the winner is lactated ringers. So lactated ringers is another one of the crystalloids, and it's specifically referred to as a balanced crystalloid. There is a number of other solutions that are in the balanced crystalloid family that also could be used, and also have some similar benefits. Plasma light, normal sol, a number of different solutions, and they all have certain features in common in that they have more electrolytes than are typically present in the strictly in sodium chloride. And really, there's a lot of literature out there that says that normal saline might not be physiologically so normal. It tends to lead to lots of instances of hyperchloremia. I can't tell you how many times we've taken an ICU transfer for patients who've had high volumes of saline administered, and you take a look at their labs just prior to transfer, and you see that they have the sodium might be a little bit elevated, but you also look at the chloride, and the chloride is usually high as well. So it might be time to look at overall in medicine, and especially in EMS, if we're going to pick one solution, maybe that one solution shouldn't be just saline. So there's some myths that are circulating around lactated ringers that I want to clear up. So to clarify some of these myths, lactated ringers does not cause an increase in serum potassium. And that's usually perpetuated by the folks who say, well, ringers has potassium in it, so you're administering potassium. And logically, it would seem to make sense to not give potassium to someone who has too much potassium. But it's all about the concentration. The concentration of potassium in lactated ringers is about 4 millimoles. So that really compares favorably compared to normal serum potassium, which is 3.5 to about 5. So it's within the normal physiologic range. If you replaced a patient's entire blood volume with lactated ringers, you will never have a potassium higher than 4. That's how much comes in the solution. So you're not really adding much potassium. In fact, overall, it would be diluting the level of potassium that you have in the serum. Not to mention, this improves the acidosis that is typically found, the various metabolic acidosis, and potassium follows the acid. So if you have more acidosis that's caused by saline, you'll tend to have an increase in serum potassium levels from that saline. In fact, that's what all the studies showed, that comparing saline and lactated ringers, the saline group, ironically, has a greater increase in serum potassium levels than the lactate group. And there's also some other mechanisms via renal blood flow, the chloride, reducing the excretion of the potassium. So really, the lactated ringers doesn't really have, a significantly negative impact on potassium. In fact, it's favorable compared to saline. And lactated ringers does not really cause lactic acidosis. Now, the sodium lactate that's contained in lactated ringers does slightly increase the lactate, but it doesn't cause hyperlactatemia. What usually happens is that the sodium lactate is metabolized by the liver into bicarbonate, which actually increases the pH. So it doesn't really cause acidosis, and all the studies really show that lactated ringers is fairly effective at increasing pH. So another myth is that it can't be given with blood products, but actually it can. There's been a couple of studies. I think there was one in 98, if I recall exactly, as well as a more recent one in 2009 that was published by the American Academy of Hematologists that really showed that when they actually took a look at it, administering blood products through lactated ringers doesn't really increase the filter weight, which they're using as an analog for creating clots that are increasing the weight of the filter. So it doesn't really increase clotting that much. And that was one of the fears of using lactated ringers, that could inactivate some of the citrates that are used as clotting agents or anti-clotting agents for administration of blood products. But that really doesn't seem to pan out to be the case, and both studies ended with saying, hey, we should perhaps really look at opening up our guidelines to have lactated ringers being an acceptable and compatible medication or fluid choice to be administered with blood products. So there's another myth that's circulated, is that lactated ringers is significantly more expensive than saline. Well, it's really not. They're both about $10 list price on Bounty. And now there's cheaper options available than Bounty, but I figure that's probably a good baseline place to go and look at list prices, see what the general costs are. And usually most agencies have some sort of volume discount available through whatever vendor they choose to go with. Also, one of the things that is true about ringers is that unfortunately it does have a slightly shorter shelf life than saline. So if you're looking for the longevity of the solution, well, lactated ringers has a little bit of a shorter shelf life. So I am bound to tell you about some of the drawbacks of lactated ringers. And it does have a couple. And one of those drawbacks is it doesn't work for everybody. I would say of all the patient populations that we have, it would work well for about 90% of them. Maybe about the 10% subset that it won't work for specifically are the acutely traumatized brain injury patients. Anybody who needs a slightly higher osmolarity in their fluids, because lactated ringers has a fairly low osmolality and low tonicity, which leads to increased, water extravasation or edema in the brain, which is bad for things like brain injuries. And this is something that's been studied. I think a patient population of about 800 patients was studied, and it was found to increase overall mortality. So if you're suspecting a brain injury, probably lactated ringers is a poor choice. In fact, your probably a better option than using even normal saline would be to use something like a hypertonic saline solution. So maybe we should be looking at carrying lactated ringers and a hypertonic saline option. But that is one of the drawbacks. Using it in acute brain injuries is suboptimal. And one of the other drawbacks is it has some more incompatibilities than saline. One of the ones that really comes to mind is ceftriaxone, which is a fairly common antibiotic, Rocephin. It is incompatible and will cause precipitation. So there are some drawbacks in the compatibility side of things. But actually, most EMS medications should be fairly safe with lactated ringers. Now, there's also a fair amount of support for the use of lactated ringers. And it's really odd that EMS, which is generally headed by emergency physicians, really hasn't adopted lactated ringers more readily. Because a lot of the professional literature from the American College of Emergency Physicians comes out to say that the data is really saying that ringers is better than saline. And they're not the only ones. The Emergency Physicians Monthly also put out an article about sepsis, how lactated ringers is better. And if you're a forward-thinking listener of our podcast, you're probably already familiar with the MCrit and PulmCrit podcasts. Well, actually, they put out 2 different articles about saline versus lactated ringers, and how maybe it's time for ringers to really go ahead and shine. So there's a number of different references that I used to put some of this together, and this is actually only some of them, because after putting together about 2 pages worth of this, I got tired of listing references and sources. But there's lots of literature out there saying that ringers is probably a better option. So is it time for saline to finally walk the plank and be driven off ambulances in the United States and maybe worldwide? Well, maybe, maybe not. I wouldn't say quite walk the plank just yet. Maybe just throw it in the brig for a backup. I think our primary solution for most applications, our go-to fluid, should be lactated ringers, based on all the information I just presented. In the slight subset that doesn't do better with lactated ringers, we should probably keep a bag or 2, so 1 or 2 liters of sodium chloride around, just in case. Now, this is something that could be, relegated to a spare roll, as a backup. But our primary, we should really look at moving forward, moving to the future, and adopting a better solution, which is lactated ringers. The reason that we haven't, by and large, is, well, saline's the way we've always done it. And unfortunately, that is a common refrain that you'll see in lots of emergency services and in medicine in general. Something's an established practice, it's really hard to break. You not only have to prove that something is, well, maybe it's slightly better, but you really have to prove that what you're doing already is significantly harmful. But I take a different approach. Let's take a step back. Let's take a look objectively. If we had to pick one of these 2 fluids, which one would it be? I know which choice I would make. Which choice would you make? That's all for this week. Until next time, keep thinking differently.